Good evening. I'm Pittsburgh City Councilman Daniel Lavelle,
And I'm Pittsburgh City Councilman Reverend Ricky Burgess.
and we welcome you to Black Pittsburgh Matters. Black Pittsburgh Matters is a series of virtual town hall meetings affirming a citywide agenda that Black Pittsburgh does indeed matter. Black Pittsburgh Matters means that Black lives matter. We must protect the health and safety of Black people. It means that Black communities matter. We must focus on rebuilding Black communities. And it means that Black wealth matters. We must focus on increasing Black employment and entrepreneurship.
The Black community has been disproportionately affected by concurrent crises, the COVID-19 pandemic and the economic crisis and race relations, which is a public health crisis. Normally, in times of crisis and great change, we'll be coming to you as the Black elected officials of Pittsburgh, having meetings across the city with our constituents, partners, and allies. Since we cannot do so safely in the current pandemic, we're now using this media and platform to come to you in the ways we can, to talk about what we're doing, discuss policy and legislation concerning Black Pittsburgh. These meetings will be available via Facebook, YouTube, and the city's cable channel. You can contact or ask questions via the Black Pittsburgh Matters Facebook page, or you can email us at blackpghmatters@gmail.com. And you can do that tonight and through our live feed tonight. Today's town hall meeting topic is COVID-19 in Black Pittsburgh Part 2. But I think I don't want to take this opportunity to pass us by the historic inauguration of Joe Biden and Kamala Harris. As you know, Daniel, you and I had the chance to privately meet him and to advocate for the work we're doing here in Pittsburgh. But as I've been watching the inauguration, my mind goes back, of course, to my mother, and who has passed, and I wish she had been lived to see this day along with my wife and my daughter who have. The election of Kamala Harris as vice president symbolizes in many ways the full inclusion of African American women in this country. They have been the foundation of our families and the foundation of our culture. And in many ways, at least for me and hopefully for them, it's a symbol of their full recognition into this country.
Agreed. And not only are they the foundation of our families, but they're also the foundation of the Democratic Party. And so for them to be placed center stage with now Vice President Kamala Harris, as well as the young woman, Amanda Gorman, who I believe in many respects stole the show. It was just really wonderful to see Black women take center stage during today's ceremony. I actually spoke to my mother earlier and she told me she stayed home and didn't go to work today so she could take time and watch the inauguration. But one of the other things I really thought about as I watched the inauguration today was, in many respects, what we saw was sort of a transition from indecency to decency. The manner in which this inauguration was set up, the president's words, all the way from his beginning to the pastor's ending and talking about finding our sort of common humanity, the symbols of unity, Amanda Gorman talking about this is the era of just redemption and the nation is not broken, but just unfinished. It was a very strong message to even those who were against our now president, Joe Biden, that we really can put the worst behind us and come together and move forward. And I just think it was a really, really well done inauguration with a very strong message throughout.
And I think it goes to our work here in Pittsburgh, right? We are leading, you and I are leading this effort locally for reconciliation, for empowerment of Black people, rebuilding Black communities. And I think that it just further emphasizes the road that we're traveling and the work we're trying to accomplish.
Agreed. President Biden in his speech said we need to set our sights on a nation we can be, but that we must be. And I think that also speaks to what we're attempting to do here in the city of Pittsburgh, really deliver a city that we must be, above and beyond not only what we can be, but what we must be. With that, we are slated to talk about COVID-19 today. And this week, unfortunately, it's worth noting that we have reached over 400,000 COVID deaths in the United States. COVID has had a devastating effect on the United States and has disproportionately affected Black Americans. According to the CDC, Black Americans are 1.4 times as likely to contract COVID, 3.7 times as likely to be hospitalized by COVID, and 2.8 times as likely to die from COVID. And it is thought that this is due to underlying comorbidities among Black Americans, as well as increased exposure due to a disproportionate number of Black Americans working in what we now call essential roles.
Long term, we need to use social dimensions of health to address the underlying causes that make Black people less healthy and more susceptible to pandemics and other illnesses. Short term, we need to work to develop trust between Black Americans and medicine. And of course, we need to take the vaccine. I need to say that 2 or 3 times. We have to, as soon as we're able, take the vaccine. To give us a clear perspective on COVID-19, the vaccines, and the Black community, I'm honored to have 4 experts, distinguished each in their own field. Dr. Margaret Pettigrew, the inaugural Senior Vice President and Chief Clinical Diversity Officer for the Allegheny Health Network. Dr. Gloucester, the Chief Executive Officer of the Primary Care Health Network. Dr. Christopher Conti, an emergency medicine physician and Baptist pastor, and Dr. Tracy Conti, a family medicine physician. Welcome all.
Just to jump in, we had both Dr. Tracy Conti and Dr. Glosser on our inaugural town hall back in August. I would just like to ask sort of the general question before we get into a lot of the specifics. In your perspective, what has changed since then? What more do we know about the virus now that we didn't know back in August when we had a chance to speak? And what have you seen change, or what do you view the situation in Allegheny County being now as opposed to what it was then?
I think what's changed is our care for patients who do contract COVID-19, both in the hospital and outside of the hospital. Now there are strategies that we can utilize on the outpatient setting that we can refer patients to decrease their risk of having severe reactions from COVID. And on the inpatient setting, we have more medications. We are better equipped to know how to handle COVID. But I also think the fatigue for COVID has changed. A lot of people have stopped wearing masks, have stopped being socially distant and doing more activities, which has increased spread. And it's something that we just need to ensure that communities understand that COVID is still there. There are increased deaths from COVID, and that we have to remain vigilant.
Yeah, I would again concur with Dr. Conti and some of those things that we've seen, and of course, all of us have witnessed the spikes that occurred over the holidays, which speak to again the factors that she's mentioned as well. With, I think, COVID fatigue and everyone just missing that ability of getting together and decided they were just going to do it anyway. And then we saw spikes, and we saw, again, a lot of problems raise their head again to the degree that they did. And I think coming out of that, hopefully, there is now a sort of reset where others are starting to take it serious again. But I think that you have still that element of the COVID fatigue. I think the other thing that's happened is, as we started off the program, with the change in administration and the change in focus in our country from the top, I think hopefully there's a trickle down to those who perhaps we're taking it less seriously, and that you would be seen more so as the outsider when everyone else is wearing their mask and you aren't. But I think that we got a long way to go to help that within our communities, because I think there's just that level of both mistrust and also this level of feeling like Tracy has mentioned, Dr. Conti has mentioned, just fatigue with all of this, and people willing to say, well, I'll take what comes with it because I'm just tired of trying to prevent it,
Yeah, this week, well, really last week, the oldest member of my church, 102, passed away because she was still living at home, still very functional. Unfortunately, came down with the virus. My son had the virus, and he did recover. We know that COVID-19 disproportionately affects Black people. In your work, why is that? Why are we so vulnerable? And I want to start off with you, Dr. Pettigrew. Tell me, what is it? What is it about us that makes us so vulnerable to this pandemic?
Well, first of all, I want everybody to understand it has nothing to do with the genes, because we're all made the same, because that is such a myth that has been that we've seen for 400 years. The issue is that because of the root causes that have made us more susceptible, we have more comorbidities in many of our communities. We have more hypertension, diabetes, and many of the other immunosuppressant diseases that we have. So we are more susceptible. In addition to that, we have this mistrust about really what is the virus, what does it do to us? And so we have not been following the guidelines as we should be, wearing our masks, social distancing. And even if we could, there's many places in the city that we can't do that. In your homes, the high-rise apartments for our senior citizens, you get on the elevator, you could fit 2 people in the elevator. There's no more common areas where they can actually socialize. So sometimes it's very difficult for them to practice social distancing, and many of them still don't have the proper equipment. They don't have the mask that they need. So there are multiple reasons why this is happening in our community, and some of them we can take care of short term, some of them we cannot. But the key is that we still need to buckle down, wear a mask, wash your hands, do all those things that we're told to do while social distancing, and try to really try to live through this is what the issue is.
Pastor Conti, and I'll use that sometimes to distinguish between both doctors. Pastor Conti, in your work, tell me, although we know the outbreak of COVID, but how does that affect people who have these pre-existing conditions? Are Black people, are we generally less healthy as a race, or does it have to do with poverty? Or in your work, obviously this virus has affected us more deeply because of the underlying conditions. But why is it? What's going on with the Black community and our health, and where do we need to go from here?
Well, I think that that is the $1 million question, but I think the answer is really complicated because COVID did not create all of these disparities in our community. COVID just became kind of the current microscope that intensifies our look at these issues. But many of them kind of came to bear here in the last 10-ish, 11-ish months, which are things like population density. We tend to live in communities where we are in closer contact with one another, more individuals living in the household compared to other communities, multi-generational households. So you're having individuals from school-age children through older adulthood, and all of the comorbidities that go with that. Where we work, many of our communities are filled with men and women who don't have the luxury of working by way of Zoom, so they have to work. If you go to the grocery store and get your groceries, you're probably interacting with a frontline worker who lives in one of these communities of higher risk. The lack of access to overall healthcare, which has been a glaring health disparity for decades in communities all over the country, and here in Pennsylvania and in Allegheny County, as well as the fact that we do, as Dr. Pettigrew mentioned, we are overrepresented in a number of these preventable death causes of mortality, such as hypertension, diabetes, chronic lung disease, chronic kidney disease, cancers, immunosuppressant diseases, immunocompromised conditions, HIV, lupus, Sjogren's disease, rheumatoid arthritis. So we are disproportionately represented in those environments as well. So again, as has been mentioned by people in the panel, it is not a genetic thing that makes us more vulnerable to COVID. It is just the perfect storm, if you will, of all of these other determinants that have been affecting us negatively in every other health area. And now it's just come to bear now. It's interesting that, we do talk about the fact that the mortality and morbidity rates from COVID are higher in our communities, and our overall morbidity from COVID is higher, but our in-hospital mortality from COVID is lower, and that's simply because fewer of our community members are being admitted to the hospital, which is an entirely other conversation about why residents in certain communities tend not to get admitted to the hospital for COVID compared to other communities. So, there is a long laundry list of reasons and disparities that help us better understand, and that's why it's even more important that we're not compounding problems by not adhering to evidence-based information. It's an incredibly emotional time, and we're driven oftentimes by emotional decision making, and then you mix in a lot of conjecture and urban legend and just totally untrue information from non-reliable sources, and it all ends up mixing together with all of these disparities. And now we have high-risk behaviors that are COVID specific: not wearing masks, not washing our hands, not staying away from others when we're sick, gathering together in congregate gathering settings, which again are gatherings of greater than 10 people with people who don't live with you. And so I think it's a combination of all of those things.
Dr. Conti, Christopher Conti, you just sort of mentioned urban myths and our sort of concern or distrust. Dr. Pettigrew also mentioned it as well. One of the things that I've heard from my constituents are they don't want to take the vaccine because it was created too fast. Can you speak a little bit about how they were actually able to create this vaccine and why it was able to be done at the speed at which it was?
Absolutely. In general, the vaccine development process takes many, many years. And when you think about it in normal time, those processes involve a series of steps which then get reviewed. There's an allocation of money, and the money isn't all just thrown at a research project or a clinical trial. As you demonstrate the validity of your data, then they give you more money, then you get reviewed. And so over time, that takes time. Well, when the death rates and the case rates became exponential in the United States, then Operation Warp Speed evolved. And so imagine taking a process that typically takes years and now pumping into that process revenue to the tune of $1 billion per month, $1 billion per month, to over 130 individual research entities in the United States, all committed to trying to solve the COVID vaccine problem. And now you're enabling those entities to share information and to work literally around the clock. You can significantly shorten a 3 or 4 or 5 year timeline. So it's a combination of money as well as resources and technology, and the fact that I think many of us have the impression, or many people in general have the impression, that warp speed meant starting from ground zero, when in reality, the research into the coronavirus family began around 2000, 2001. And with SARS and MERS and a whole another group of coronavirus strains. So the virus itself, although it was new to our bodies, this COVID-19 strain, coronaviruses were not new to the human body, nor to the research community, nor was the technology, the mRNA based vaccine development process. That's also about 20 years old. So you took a process that had been in the works and had been ongoing for 2 decades, and add to that personnel and technology and an abundance of money. And that allows you to solve a lot of problems a lot faster than the normal time frame. So I think that combination really makes a difference. And if I were to just add some other information that may help alleviate some of the skepticism, at the helm of a lot of this research is a African-American woman, a PhD, Dr. Kismika Corbett, who is by Dr. Fauci's own account, his right-hand person in the development of these processes that led to the development of the vaccine. So again, just because she's an African-American woman doesn't mean she's automatically vetted. But in my mind, I know she's a brilliant scientist, and I'd like to think that she would not introduce things into our community that would be hurtful or harmful to our community. So that, for me, gives me a significant amount of confidence when it comes to this specific vaccine.
Dr. Pettigrew, let me ask you kind of bluntly, right? Talk to our audience a little bit about the vaccines, but my blunt question is the vaccine safe? Like, you've seen on Facebook and through social media, people believe that they take the vaccine, they will get COVID-19. If they take the vaccine, they will grow 2 heads. They will, get under a variety of instantaneous problems. Talk about the 2 vaccines, at least that I know about, and I straight up asked, is the vaccine safe?
So a couple things like that Chris added when you talked about the creation of the vaccine. It's an mRNA, which means it doesn't have the actual vaccine in it doesn't have the actual organism in the vaccine, which is phenomenal. So they're not getting any piece of the vaccine. Of course, we know there's two different types. There's many types, but the 2 that are on the market now are Pfizer and Moderna. And they're both very safe, 94% and 95% effective. And I say they're very safe. I'm sitting here. I had the vaccine. Both Chenis and I, my husband, are in the study. I had the vaccine back in September. I had a sore arm, and that's all. I had a shot in September, shot in October, blood drawn, and we're going back this week for Chenis to get his vaccine. So he had the placebo because they unblinded him and they unblinded me. But I'm sitting here healthy. I had no symptoms. Some of my friends had very, very few symptoms, such as a fever for a day, and it went away. Most of the people who were in the vaccine study had a sore arm for 3 or 4 days afterwards, and that was nothing else. So it is very safe. And so when you compare getting the vaccine compared to what's happened in the past, look at what happened with polio. I mean, this is up at that scale. People are dying. Many people are dying. And compared to taking the vaccine, which we know is very safe, to really losing lives, then it's something we really need to consider. The integrity that's involved in the studies that everyone on this panel can really talk about is how very extensive getting into those studies, even doing the research, is now compared to it was when they were doing many of the experiments in the past. So very stringent and very, very, very close monitoring of all of the studies that are done. So it is safe. It's very safe. I would encourage everyone to take it. We need at least, they say 70% for us to make sure that we're moving toward the direction. We really need about 95% to really make sure that this virus is going to be under control. And that's 95% of folks taking this vaccine.
Wow. So towards that end, I read an article this week that was in Kaiser Health News that talked about the disparity between white Americans and Black Americans actually receiving the vaccine. And I'll start with Dr. Gloucester, but it said in Pennsylvania, 1.2% of white Pennsylvanians have been vaccinated so far, but only 0.3% of Black Pennsylvanians. Can you talk to us a little bit about what's happening? I mean, given that we know on one end, we're more likely to catch it, we're more likely to die from it, but that only 0.3% of us have been vaccinated. Can you talk about a little bit about what's happening with the rollout and also what role community health-based centers can play in expediting the vaccine getting into our community?
Sure. I'll take the second part first in that I'm thankful that our community health centers, which are in underserved areas throughout the state, have been included in the rollout of the vaccine. And so I was very encouraged to learn that early on that we would be a part of it. And that helped me to answer questions to others around the health equity issue as far as the distribution and rollout of it, and that I had a high level of confidence that that was a focus. I really believe, to the first part of your question, the issue around African Americans actually getting vaccinated points to what we've all been just talking about. The fact that if you talk to the average white person, whether they are concerned around safety, being experimented on, being injected with a chip of some kind, to even hearing about something spiritual and the mark of the devil. I've heard all of those things in the Black community. So there was just from day one just a strong level of mistrust in our communities. So I don't think that it was surprising to hear as the vaccine rolled out that not a lot of us got the vaccine, as again, Pastor Burgess has mentioned. I was saying this in calls of community health centers and also Black Equity Coalition. We have meetings with Dr. Levine with the state. And a couple of months ago, I said this when there was a question around equity. I said, your bigger question is, or your biggest concern needs to be, you can get 1 million doses into our community, but if no one takes it, then it's not going to help. So we really have to ramp up our efforts. I was saying this months ago around acceptance of the vaccine. And that to one extent, I think some would say is somewhat insulting, that somehow in 2 months you're going to make up for all the mistrust over 50 years and everything. But at least you need to start addressing it and listening to people and trying to help with those concerns. I know with my own organization, being an organization of 130 employees, having said that, most of them minorities, we had question and answer sessions and sat down and talked about it and allowed others to voice their questions and concerns, and quickly saw, what was initially maybe only 30% of my medical staff being sure they wanted it, before the vaccine rolled out, to once it came out to somewhere around 80% of the medical staff saying, yes, I want it. But that was, a case of, well, you can't just, deliver the vaccine and say, who wants it? You got to start talking about, all these issues that were already on the table before the vaccine came out to help to improve the acceptance of it. And some of those things have been, the great points that Dr. Conti and Dr. Larkins Pettigrew have mentioned, that to talk about the myths and allow that information to come from trusted individuals like other Black physicians, to talk to our minority community and also talk about the fact that an African American woman actually helped develop the vaccine, and people say, wow, I didn't know that. And then lastly, the fact that, as Dr. Pettigrew has mentioned, and I know that some of us on this panel, and likewise myself, got the vaccine, to be able to tell people, yes, I got it, I'm fine. I think that helps tremendously, because some individuals have that's the last thing they've said. Well, I'm going to wait and see, when I see someone that I know get it and see how things turn out, and that at least they got to that point. But I think we got a lot of work to do, and I think that it involves the people like us on this panel and other trusted members of our community just working tirelessly on this issue, because I really think that that's at the heart of such a small number of individuals within the Black community getting it for the most part. There might be distribution problems, as we know there's distribution problems across the state, but such a big disparity, it goes along with what I've been hearing for months.
think just to add on to Dr. Gloucester's point, the distribution piece of it, if you look at what was 1A or those initial distribution, it was to healthcare workers. When you look at the disparities on who are those frontline healthcare workers, like physicians, like nurses, and when you have disparities in racial inequities based on education from systemic racism based on our schools, and you have less African Americans, less minorities in the healthcare field, and if that's who they were targeting for their initial vaccination, of course those numbers are going to be lower. In addition to all the other misinformation. And so I think we'll have to look to see as it expands to the broader community, what that uptake in vaccination rates are.
Years ago, I was actually in a social setting with a friend of mine, a Black physician. And he said something that it stunned me and it struck me. This was a long time ago, but he mentioned how, as a Black physician, although he had Black patients, he had some Black patients who would not come to him, Black people rather, who would not come to him because he was an African American physician. And so because of that, I decided that I was going to make sure that I had an African American physician, an African American dentist, an African American lawyer, that those who empower me and equip me and take care of me are all people of color. I guess I want to start with I want all of you to talk about this, because I think it's something we need to at least lay on the table. Why, and it's really a two-part question. Why do African Americans have this distrust of the medical profession? They have a distrust for certainly, medical research institutions. But then, honestly, sometimes Black people have a distrust of Black doctors. And why do you think that is? Is it just racism? And I'd like to get all your thoughts about that.
Well, I think that, it goes back much further than Tuskegee. Prior to Tuskegee, there, was what was called the medical plantation, where, individuals, even one who is heralded as being one of the fathers of modern gynecology, conducted experiments on slave women without their permission. And doctors would go from plantation to plantation and state that they had these magical cures that would make slaves more productive in the field and more fertile. And so it started well before that skepticism and that fear started long before Tuskegee. But then Tuskegee comes around in 1932. And it's interesting because there were far more white people in America who had syphilis at the time. And syphilis was the epidemic of its age then. And it was a public health problem largely among white America, but they didn't have a cure. So they went and they found this large population of almost 300 Black men in Tuskegee who had syphilis, and they promised that they would be getting free medical treatment, burial insurance, and free meals, all in exchange for getting treatment for what they were telling them was called bad blood. Back then you either had bad blood or you had consumption. No one really knew what either one was. So the experiment was supposed to last for 6 years, but they found the cure, or the standard of care treatment at that time, which was penicillin, about 3 years in, and they never introduced the treatment to these 299 Black men, and they just allowed them to go through the natural disease progression of syphilis, and they took notes. And that's why a 6-year study became a 40-year study and didn't end until 1972, until someone blew the whistle. So, the skepticism is real. But I guess if I could borrow again from Dr. Fauci, and I'm not saying that he has all the answers, but he acknowledges these disparities and the history behind them. He said, but all I can tell you about this vaccine at this time is that the group of individuals involved in the development of the vaccine is perhaps one of the most diverse groups in the history of vaccine development. The process that exists now is very transparent, as well as independent of government and drug companies and their interests. And so, when you put all of that together, It's a matter of how do you package that and communicate it through vettable, reliable resources within our community. So where are our already existing help resources? The church, for example, is a help resource that has been used and studied and shown to be very effective in communicating information on a whole wealth of subjects, including healthcare. So we've got to be able to package the truth in a way that it's coming from a mouthpiece that is viewed as reliable and credible. And that's the challenge, because that means, we've got to be creative. A lot of this is a lot like ministry, and I'm sure Pastor Burgess can attest. It's a lot like ministry is trying to introduce information and resources to individuals that you feel strongly about in a way that makes them want to buy in. And you have to be creative in that approach. So, how we do it, that's the tough challenge. But people on this call and the people that we work with who are like-minded and committed, I think we have the resources here in Pittsburgh to do it. We've got the Gateway Medical Society. We've got a fairly large group of African-American physicians and public health workers and leaders in industry and politics and business who can help, undergird our communities and solve these problems together.
Other people.
So I wanted to piggyback on what Chris said, because we can talk about 400 years of slaves. We can talk about all of the things that have been done to us in this country around medicine. But my husband and I spent some time on campus. He was the vice president at Tuskegee University. I took care of the students there, but watched many of the women and children of these men who have been born, looking at all of the defects that occurred. I worked in John A. Hospital, where they still had the iron machine, and a place where people were just mistreated. We lived in the Dibble house. Dr. Dibble was responsible for all those Tuskegee experiments. It's still very close to our history, and so it's very hard to come away from that thinking that people are going to treat you well. Less than 10 years ago, they were sterilizing women, Latino women, in the prisons in California. Distrust is all over the place because the medical profession has not put themselves out there to be trustworthy in many situations. On the average, but generally, the overview of what medicine does is really treat patients with integrity. And really, we do take care of patients, whether we're Black or white. We really have taken an oath to do what we need to do to take care of our patients and to make sure that they have the best care possible. So then the second question you asked, but there's still this distrust. So let's weigh that. So we talk about what happened with Tuskegee and all the things that happened in the past and how people don't distrust us. But yet in our hospital systems today, many of us are treated with disrespect. Many of us are not given the proper treatment that we should do right today. You can be admitted to a hospital today and be treated like you were a Black slave 400 years ago, as in some of these institutions, whether you have an unconscious bias or you have just, outright bias. People still feel that sometimes when they go into the hospitals, and many times they don't access care. So when you have access care, you're not going to access it because you don't trust the system. What we want to do, and everybody on this call has been doing their entire lives, is trying to change that way, letting people know that you can trust the system. There are people in the system who will take care of you. And they don't have to look like us, but many of them do look like us because we're leading this march to make sure that that we understand the science, you understand the science. Please trust what we're telling you because things have changed. We've moved a long way from this whole issue of what happened as relates to the Tuskegee experience. However, those 400 years of slaves did more to us than just make us distrust the medicine. It also made us distrust Black physicians. There is a long history, and if you study the history, there is a long history of what has happened over the years. It's gotten better of why Black patients don't trust Black physicians. And it really is that brainwashing. If you think that I am less than, if you think that I am not as smart as, if you have been told your whole life that you yourself wasn't worthy, right? What are you going to think about someone else who says they're a physician, although they've been educated, same school, same systems, but you're not going to trust that because all your life, your ancestors, your parents, your grandparents, they told you not to trust the Blackness because of their own self-hate. So they would rather go to someone who they think is brighter, who they think can give them better care, and that's why they distrust Black people and they choose white people to go to. But at the end of the day, we trust the science. We know the science. We're close to the science as it relates to the virus and the vaccine. We want our constituents, we want our neighbors to trust the science because they need to actually take the vaccine.
And just to piggyback off of what Dr. Larkin's pedigree talked about, that is racism, right? Dr. Kamara Jones kind of broke it down into three kind of structures. There's that institutionalized racism. That's like that structural barriers, the inability for us to get into medical school, the structures that were set up in place. And then you have your personally mediated where, people are saying less than, that these doctors got into school because, of a program, not because they were worthy. But then you also have, internalized racism. And I think there's not a lot of education about how much impact the system and structural and personal mediated racism. And you continue to say that, and people start reflecting on themselves and seeing themselves as less than. So they're going to see another Black physician as less than. It just erodes that individual sense of value. And the only way that we can combat that is through education on all levels, education of health professions about why is there mistrust, education on community level about, racism and structural racism, and that there are trusted individuals, but it takes us going out to the community to establish that trust, to build relationships. And to have programs like this to be able to, speak truth to what's going on.
I can't help but use this moment, Dr. Gloucester. We're talking about bias. I think one of the best kept secrets in the Black community is actually Alma-Hillary in Homewood. I think people do not understand the range of services that you offer, that you are either, you may be the first or second largest in terms of a budget institution in that community, and that, they don't have to go to UPMC or to Allegheny General Hospital to get care, or there are things they can get right in their own backyard. And so both for COVID in general, Dr. Gloucester, if you just kind of give a sense of the services that these community-based health centers give, and yours in particular.
Sure, absolutely. First of all, Alma-Hillary is part of a corporation of health centers. We're under the umbrella of Primary Care Health Services. Alma-Hillary was our first health center established back in 1977, after it being named previously the Homewood Neighborhood Health Center that started in the late 60s, one of the first community health centers in the nation, federally qualified community health centers in the nation. But that corporation has expanded to now 9 community health center sites throughout the county, in McKeesport, Braddock, Homestead, Hazelwood, the West End, the Hill District, East Liberty, and Wilkinsburg, as well as Homewood. So really, that's the first message, that our organization has a health center in most of the neighborhoods throughout the county, and then you have really 6 other community health center organizations throughout the county, so that the services are available. Second thing I'd like to emphasize is, to your question, community federally qualified health centers are tasked with being completely comprehensive. So we not only offer medical care for newborn babies through the elderly age ranges, but also a complete comprehensive array that would include women's health. It would include dentistry. We have dentists and dental care at our sites. We have behavioral health and therapists and access to those services. We at Alma-Hillary also have a podiatrist as well, so someone specializing in foot care. We have our own pharmacy. And this is a great, service that's a secret, I think, to many, in that not being a commercial pharmacy, those medications that people would have to pay for out of pocket or even by insurance, the prices are much lower because there's no middleman. We're not in the pharmacy business, if you will. We're in the business of serving the community. We have our own lab. We have our own social services team that goes out into the community. And so really, we're talking about just a total healthcare service delivery that we have, again, throughout the county. And as you said, Almillary is our headquarters. It's our best kept secret right there in Homewood, and one of the first community health centers.
I want to ask a question, and I hope I say this right, about B117, which is sort of the new strand of this. What I've read is it's approximately maybe 50 to 60 times more transmissible than the previous version. One, what do we know about this new strand? And then two, do we know if the current vaccines will also protect us from it?
Well, I think so. That strain is one of many. Viruses are living organisms, and they are constantly mutating because they also are looking to survive, and they survive by being transmissible from living organism to living organism. There was likely a mutation that allowed this zoonotic transfer from a bat to a human in the first place. So viral viruses in particular, mutations are not uncommon. And there will be more vaccine or more viral mutations that will occur within this strain, within this family of viruses. So they're not unexpected, but in terms of how this vaccine works not by killing the virus, but this vaccine works by allowing us to produce antibodies to the spike protein, which is on the surface of the virus, which doesn't seem to have changed significantly. So although there are teams working on the contingencies that may be required once the virus mutates and is no longer susceptible to the vaccine, there's no evidence right now that the susceptibility has changed. Some of the estimates I've seen would say it's going to take several years worth of mutations before that happens. And then I've read some in other places where it may not happen at all as long as the spike protein isn't affected, because that's what this vaccine targets. This vaccine is actually allowing your cells and my cells to manifest the spike appearance to them so that our immune system really sees a mimic of the virus in some of our own cells. And so that when the human body then is exposed to the actual virus, our immune system believes it's seen the virus before, and therefore it already has antibodies against it. So, so there are some strains, and I think what makes it more transmissible is the fact that the virus is trying to develop strategies that it can hide within a living organism and not be destroyed by the organism's immune system. And so this transmissibility is how the virus survives. There may be strains that will come out that will be even more easily transmissible. And then if you have strains that begin to not look like what our immune system is prepared for, then we're going to, the next newsworthy thing may be people who've had COVID who now are getting reinfected by a new strain. And it's because the new strain doesn't resemble the original strain, and our immune system now has to start over, or, not necessarily start over, but it will have to develop antibodies to the new virus because it looks different.
And
Okay.
just to piggyback onto that, I think, outstanding explanation by Dr. Conti as far as the comprehensive nature. But again, what I've heard that that even emphasizes even more fully what he said is that they've actually proven, to your question, Councilman Lavelle, they've proven that the vaccine, antibodies produced from getting the vaccine, as well as antibodies from having the disease, have been shown to kill the virus. So we're certain that it does work, and at this point. So I think that's great news.
Thank you very much. Micah Campbell Smith has been monitoring questions from people watching online. So I want to bring her on to be able to ask some of those questions. But as she comes on, I do have a question for Dr. Tracy Conti, given that you're a family physician. For those families where we have children in school, as PPS begins talking about opening up in February potentially, as other schools are talking about hybrid models, what advice or what do you think we as parents should be giving consideration to as we potentially look at sending our children back to school?
To know that the school spread has actually been relatively low. There have been schools that have been open throughout the COVID pandemic, and there's been very little school spread. But it's important that you talk to your children about continuing to wear their masks, ensuring that your school district is utilizing social distancing, so they're decreasing the amount of children in classrooms, if they're making accommodations for that. Making sure that there is hand sanitizer in use if they're unable to wash their hands in between, and just that education around those three things: masking, hand sanitizing, as well as social distancing is important. What we have seen and what I have seen is a lot of times that happens in the classrooms, and then kids get on buses and they take their masks down. And so it's really important that every child be given the education about the importance of keeping their mask on for the entirety of their trip, and ensuring that that parents also are masking and when they're picking up their children and providing a good example for their kids.
Inside of the schools, should the children also still be 6 feet apart? Is that still the recommendation of how to set up the classrooms, how to keep them apart at lunch and things of that nature? Should that be part of our educating to the children that you really can't play like you would normally play?
Yeah, so that is still the recommendation. There have been kids that are still doing sports, and they have been shown that there is also a little spread with those, but you still want to ensure that before they're going to sports that they are washing their hands. When they come home, that they're showering, washing their hands, and being safe. Can you completely eliminate the risk of COVID? No, but we do know that the majority of children, if they do contract COVID, do not have the same effects that adults do. The biggest risk is carrying it home to adults and vulnerable patients.
If I could just add one thing to that, because we all know, the number of total hours that our young people spend on social media and the internet. I would encourage parents and guardians to establish themselves as their child's COVID expert. That doesn't mean you have to know all the information, but I think the language that you use is that you need to tell me what's going on with, what's the talk around COVID among your friends, and so that you can begin to help break down some of those myths, because these kids oftentimes do not believe that this virus is what it is. So they'll go to school where it's harder for those practices to be monitored, just because there's dozens and dozens of young people and a much smaller number of adult supervisors. And then they will also begin to come up with strategies to gather, right? They will gather. And so as a parent, you have to really be engaged in this effort, no more or less than normal. But I'm just saying, just some of my experiences about some of the spread events that have occurred in our county have been from students having impromptu or non-parent sanctioned parties and gatherings, whether it's for graduation, homecoming, whatever it was. And they're doing these things because of the chatter that they're engaged in amongst themselves that implies that COVID isn't real. And so I would encourage parents, this is another great opportunity for parents and guardians to become more engaged in those conversations. And they're hard to have, but I think that your children will appreciate it, because deep down, a lot of them do want reliable information from reliable sources. And if we're not providing it because we assume they're getting it from school, then they end up going to other sources for information. And so it also helps us keep ourselves current with at least some important information about health and safety in terms of masks, and reminding your children, when you're wearing that mask, it's got to cover your nose and your mouth. Here's some hand sanitizer. Show me your backpack. You got some hand sanitizer in there? Here's a bottle. Make sure you use it. Just simple little things. Sending them a text message. They're on their phone 3 hours out of every day. So chances are, if you send them a text or send them something, they're going to read it, and they may never acknowledge you or say thank you, but they'll remember it and they may put it into practice. And that might make the difference between them, putting themselves in harm's way and bringing something home that affects the multi-generational household that they live in, or them stepping away and saying, you know what, I'll eat over here by myself today because nobody at my table right now wants to wear a mask. So I would encourage that conversation.
So we have a few questions. The first is there a strategy for Alma Illery to partner with the University of Pittsburgh Health Center?
The first partnership I can tell you about is Dr. Conti and I we're engaged Black Equity Coalition for our communities, and that's one in which our organizations have pledged a partnership. Also, to know that Alma Illery and Primary Care Health Services, we're absolutely engaged in partnerships both with UPMC and Allegheny Health Network, really all the health systems, and that I have a firm belief as a CEO that really the strategy moving forward is one in which all of us, all of the community organizations, that we look at how we can better help our communities by, instead of in the past being siloed in our tireless work and doing a great job, but we're working all by ourselves. But moving forward to engage in as many partnerships and as the Black Equity Coalition's also really pushing is the notion of a hub and spoke model, where we have really a comprehensive network of providers working together in our communities. And so the health systems are definitely a part of that. And yes, Primary Care Health Services is involved with that.
Thank you. And we also had, when the vaccine is available, will you be able to access it similar to a flu shot, or how will vaccine distribution work?
I can take that question just to make sure that everybody knows that, of course, we have been, as a state, really behind many other states as it relates to the rollout of the vaccine. And so that we have had to come up with our own plan, working with the public health department in many of the institutions that are around us. At Allegheny Health Network, we are still taking care of our 1A constituents, even though we've moved all the way down to 1C, because the governor said that we should take care of those patients who are 16 to 65 that have comorbidities, as well as those over 65 years of age. The issue is the fact that we don't have the vaccine that we need. So we have a plan, and we have a plan that will take care of all of our patients throughout the city and the county. But the issue is we don't have the vaccine. So as it relates to taking care of underrepresented minorities and how you'll get the vaccine, we have mobile units that will be throughout the city. From the AHN side, we have contracted with PNC, so that's going to be wide open as far as making sure people are getting the vaccine. I've partnered with Dr. Conti, who has also lined up a number of churches for us that we've worked with before from the Allegheny Health Network side to make sure that we can use parking lots in order to have our mobile units in order to dispense the vaccine. But at the end of the day, we're sticking to trying to make sure that the individuals with the highest risk of actually perishing are going to be taken care of first. So all of our frontline workers, all of our aged individuals who are 75 and above, and then we're moving down to take care of everyone as we're supposed to. When we get the vaccine all over the city, even UPMC, I mean, sure that they have a plan. When we get the vaccine, we have a plan to make sure that we're going to make sure that our communities get the vaccine. So it won't be similar to the flu. Most of the time when you get the flu vaccine, that you can take it and you can go. Remember, you have to be monitored for a period of time once you get the vaccine, because we want to make sure that everyone leaves the facilities safe. So it will be organized and we'll make sure it's available for everybody.
And I just want to give a shout out to the Black Equity Coalition, because that is something that we're actively working on to try to partner with AHN, with UPMC, right, with the Allegheny County Health Department, with the pharmacies to ensure that our communities have equity with regards to distribution of the vaccine, and that there is a group making sure that we are providing oversight to ensure that our communities in Homewood, our communities in McKeesport, our communities in Hazelwood all have access to vaccines.
And the last thing I'll add to that is, I think the good news is that the federally qualified health centers are part of the effort, and where you would be a patient, and to piggyback on to what Dr. Larkins Pettigrew said, as we are, yes, following a tiered approach, but a patient of one of our health centers and you fall into that category, yes, you can call and schedule an appointment to get the vaccine. And we've already started to do that. But to also piggyback on what Dr. Larkins Pettigrew said, and that is that right now, the issue is supply, because the supply is just barely trickling in, and we're getting bombarded with phone calls, and some are large practices that have 200 people in their medical practice, and they want to know, can we vaccinate them? But we're also getting individuals again from our community that fall into these categories and want a vaccine, and so part of our plan involves, number one, those who are currently our patients, you can call and get on a list to be vaccinated. Those who are not our current patients, we're going to be having vaccine distribution days and events to vaccinate in our community. But lastly, the difference, as Dr. Larkins Pettigrew said again, is that we have to follow these guidelines as far as safety, and yes, you have to wait at least 15 minutes after the vaccine. We're going to have stations, if you will, to monitor individuals and to make sure they're okay and make sure that it's a safe event. And then lastly, to make sure that you can follow up in 4 weeks and get your second vaccine to complete the series and make sure that you're fully immunized.
Thank you all for that information. This was very informative for me, and I hope for all those paying attention. We are going to do everything we can to ensure that this video is seen by as many within our community as possible. I believe you all answered a lot of really pertinent and important questions for us, and provided a lot of clarity as to why we should actually go get vaccinated and take the vaccine when it is available. Unfortunately, that is all the time we have for today's show, and we want to respect your time, and we thank you for the time you've given us. We do want to thank all our guests, starting with Dr. Margaret Pettigrew, the inaugural Senior Vice President and Chief Clinical Diversity Officer for Allegheny Health Network, Dr. Glosser, the Chief Executive Officer of the Primary Care Health Network, Dr. Christopher Conti, an emergency medical physician and doctor, and Dr. Tracy Conti, a family medical physician. In order to have significant investment in the Black community, it is imperative that we make our community safe and peaceful. And towards that end, I'm going to encourage everyone to, when you're available and when it's available to you, to please get vaccinated.
I want to thank all of you for watching and participating in this town hall meeting. Remember, you can watch this show on Facebook, the city's YouTube channel, or the city's cable channel. A new meeting will occur every Wednesday. I also want to, we're all people of faith, and I wanted to say one personal note. My own church has not been open since March, and that's under the advice and direction of Reverend Dr. Condi. And I know, and I'm telling you, that churches mostly should not be open at this time. Hopefully in May or June, we can be safer. But the way we do church, especially Black churches, it is a recipe for disaster. It's a lot of old people together in not social distancing and doing high-risk things. So pray like I do, pray and worship from home and remotely. I believe by working together, united in purpose, we can transform our city, strengthen it for all of its residents. Pittsburgh can only be a city for all when it becomes a city where Black Pittsburgh matters. Good evening, stay safe, and be blessed.